much visible at the bottom of the screen. With this, I would like to once again invite Dr. Sanjeev CC and to hand it over to him to take forward for the evening proceedings. Over to you, Doctor.
Yeah. Good evening, Mr. Chetan. At the outset, I would like to thank Sanofi team for giving an opportunity to speak on this topic. It's my pleasure and honor to associate with psychiatrists, especially on this topic, because it's a gray area overlapping between the neuropsychiatrists. And it's a very interesting topic, and it's you learn more through video than through theory. So I'm going to show a lot of videos today. Coming to the drug-induced movement disorders. Drug-induced movement disorders are the commonest movement disorders encountered in clinical practice, both neurologists as well as psychiatrists. It is due to secondary to blockage of dopamine receptors, especially D2 receptors by neuroleptics as well as non-neuroleptics. I'm using the word both neuroleptics as well as non-neuroleptic group of drugs. Wow, what is called semiology in epilepsy, we call phenomenology in movement disorder. Once you know the phenomenology in the movement disorder, you can make a diagnosis of the following signs. Say, the drug-induced movement disorders can manifest in various ways. Could be Parkinsonism, could be Tardive phenomena. Under Tardive phenomena, we have chorea, dystonia, tremors, akathisia, myoclonal tics. And as a idiosyncratic reaction, it can manifest as NMS. So one should know the phenomenology before making a diagnosis. See, among all the theories put forward after several biochemical research, the commonest theory still hold goods in the drug-induced movement disorder is the blockage of D2, sometimes D3 dopamine receptors by various drugs. So this theory still holds good. I'm just giving the example how the older type, typical antipsychotics, that is older antipsychotics versus newer antipsychotics. The older antipsychotics, they mainly block D2 receptors. They got less affinity towards the 5-hydroxytryptamine 2A receptors. Whereas the newer antipsychotics, they not only block the low to moderate in the degree of blocking dopamine receptors, D2 receptors, they also blocks the mainly 5-HT2A receptors, 5-HT2C, 5-HT1A, 1C, etc. And the future atypical antipsychotics is just a graphic representation where the researchers wanted to have neither D2 receptor blocker or 5-HT2C receptor blockers to avoid the side effects. So just giving the examples how the typical, that is traditional antipsychotics, they got high affinity towards the D2 and low affinity towards the 5-HTA. Whereas atypical, there is a newer antipsychotics, they got moderate to high affinity to D2 and very high affinity to 5-HTA receptors. Among the atypical, clozapine has got least effect on D2. That's why the extrapyramidal side effect is less in clozapine. But it has got high affinity towards 5-HTA receptor. This just to show the various drugs, how they block. As I can make out in the case of clozapine, the red one suggests as dopamine. Chlorpromazine block mainly D2 receptors predominantly, whereas the clozapine blocks the blocking effect on D2 receptors is very, very minimal. That's why the side effects profile, especially extrapyramidal side effects profile, is less in clozapine. Coming to these movement disorders can manifest acute, subacute, or chronic. It could be focal. Focal means involving one part of the body, either hand or face or the leg. Then segmental. Segmental means whole upper limb or lower limb. Then hemi-generalized, whole half of the body. Then generalized, both upper and lower limbs. Majority of drug-induced movement disorders do well, except Tardive phenomena. See, these are the drugs, you should be aware of it. It's not only neuroleptics. We have antiemetics, anti-migraine drugs, anti-epileptic drugs, then cardiovascular drugs, anti-vertiginous drugs like cinerizine, etc., which are known to produce drug-induced movement disorder. What are the risk factors involved? These are the general risk factors I'm highlighting. Advanced age. You should be careful when you're treating patients with neuroleptics in advanced age patients because they are more prone to develop side effects. Then presence of underlying disorders like substance abuse, mental retardation, dementia, schizoaffective disorder, diabetes, head injury, past history of head injury, then severe anemia. These are the people who are prone to develop side effects easily. That's why you should be careful. Coming Coming to the acute, we have akathisia and dystonia. Number 2, overdose, that is drug-induced Parkinsonism. Number 3, idiosyncratic reaction, that is NMS. Then coming to the chronic, Tardive syndrome. Under this, we have got various subtypes. Coming to the exam, acute dystonia. What is dystonia? Dystonia is nothing but involuntary excessive muscle contraction resulting in abnormal posture or repetitive twisting movements. It is basically due to blockage of D2 receptors, where these are the drugs which are known to produce acute dystonia. Acute dystonia means usually within 3 to 4 hours. Be aware of it. Unlike chronic. Chronic usually take many weeks and months. So what are the drugs which are known to produce acute dystonia? Right from the antiemetics like metoclopramide, prochlorperazine, atypical antipsychotics like olanzapine, risperidone, then the typical antipsychotics like haloperidol, fluphenazine, chlorpromazine, etc. What are the subtypes in acute dystonia? One can see acute oculogaric crisis, or orofacial dystonia, or cervical dystonia, sometimes generalized dystonia. I'll just show you a few videos. This elderly lady came to our OPD with acute painful spasm in the neck with mild backward turning of the neck. After taking the history, we found that she was taking antiemetic drug. She has received injection antiemetic, one of the antiemetic drugs, so-called Stemetil. Following that, she developed acute dystonic reaction. Eventually, she got better after stopping and starting dopaminergic drugs. See, this is the culprit. See, this Stemetil is abused both in neurology and psychiatry because of our preoccupation with in busy OPD. We keep left and right using this Stemetil. Another unusual case of abdominal dyskinesia by domperidone. This is the acute dyskinetic movement involving mainly the abdominal muscles as a reaction to domperidone. Similar case, again, domperidone again is an antiemetic drug, again abused commonly in our clinical practice. This guy, similar abnormal dyskinetic movement following exposure to domperidone. He is developed within a few hours after the exposure to domperidone. Coming to the acute dystonia. This is one of the commonest manifestations with the neuroleptics. Within few hours, we can develop, and it can be very painful, inability to swallow, and even inability to speak also. This another suspected Down syndrome because of his behavioral problem was haloperidol was used, and he has developed within few hours acute jaw opening dystonia with oculogaric crisis. You can make out the uprolling of eyeball and with a fixed jaw opening. So more than one movement disorders can be noticed in a given patient. This is a nurse working in the hospital. She exposed to metoclopramide and perinom, and within few hours she developed acute cervical dystonia. Eventually she got better after stopping the drug. In a given patient, more than one movement disorder can be noticed, like both oculogaric crisis, jaw opening dystonia, and cervical dystonia. This middle-aged lady exposed to neuroleptic, haloperidol, and she came to us with this kind of movement. She had a oculogaric crisis with uploading of eyeball, mild jaw opening dystonia, and cervical torticollis. There's a backward bending of the neck. See, this all develops within few hours after the exposure. The more commonest pathophysiology being the blockage of dopamine receptors with followed by increased sensitivity to the postsynaptically increased sensitivity to the dopamine. How do you treat? In the olden days, we used to give Finargon, but still people are using Finargon. But the only drawback of Finargon is if you exceed certain dose, it can have a paradoxical reaction in the form of exaggerating the underlying extrapyramidal side effects. Nowadays, it is replaced by diphenhydramine or benztropine or biperdine. Even sometimes, if nothing is available, intravenous diazepam also replaces a safer role while managing the acute dystonic reaction. Coming to the acute akathisia. What is akathisia? Akathisia is nothing but restless behavior and with irresistible urge to move the body. They may not sit or stand in a single place. They keep moving, wandering from one place to other place. It could be acute, subacute, or chronic, like Tardive phenomena. Acute can develop within few hours after the exposure to the neuroleptics. It is due to blockage of dopamine receptors along the mesolimbic system. Even both atypical and typical antipsychotics can cause. I've seen SSRI causing Acute Akathisia. Flupentazole can causing. Even the cocaine abusers you can see the Acute Akathisia. Along with there is mental restless behavior, they do develop the physical movements, so-called complex stereotypic repetitive movements, which I'll show you subsequently during the video session. This guy has developed a exposed neuroleptic and he has developed acute akathisia in the form of he wants to get up and walk and is assisted by the bystander. Along with this restless behavior, he do develop physical movements in the form of stereotypic repetitive hand movements. So both the physical as well as mental aspects of changes can be seen in acute akathisia. This middle-aged lady exposed to haloperidol, within few hours she developed acute akathisia. She keep on moving from one place to other place. Another case of acute akathisia, I want to highlight you both physical repetitive movements as well as restless behavior you can make out in the same patient. He keep wandering from one place to other place along with repetitive hand movements. These are stereotypic hand movements. How do you manage acute akathisia? One is, of course, you should stop the offending drug. You can give a trial of propranolol. You can go up to 80 milligram. Clonazepam, clonidine has been tried. Recently, mirtazapine has been tried in the management of acute akathisia. Coming to the third movement disorder, drug-induced Parkinsonism. Drug-induced Parkinsonism is quite common in our clinical practice. Unless until you take a detailed history, it may be mistaken for idiopathic Parkinson's disease because it could be asymmetry or it could be symmetry. And all the signs of typical Parkinson's disease can be elicited, like resting tremor, rigidity, bradykinesia, even postural instability. It is due to blockage of mainly dopamine receptors. Majority of them develop within 1 month. In another 20-30% of cases within 3 months after exposure to neuroleptics. The best way to treat is either you reduce the dosage or switch out to other antipsychotics. If the patient, if the symptoms disappears completely, it's most likely it's a drug-induced Parkinsonism. In case if it persists, it indicates under presence of underlying subclinical Parkinsonism, which is just precipitated by neuroleptics. Another way of differentiating is you can subject, if you are in a doubt, you can subject a patient to PET scan. In the case of drug-induced Parkinsonism, there will be no normal uptake of fluorodopa. Whereas in the case of a pre-existing Parkinsonism, there is a idiopathic Parkinson's disease, there will be decreased uptake of levodopa. How do you treat? Of course, you stop the offending drug. You can initiate with anticholinergic or amantadine. In certain cases, especially caused by dopamine depleters like tetrabenazine or reserpine, you can give a trial of levodopa and dopamine agonists. So these are the drugs which are known to produce Parkinsonism, right from older antipsychotics like chlorpromazine, fluphenazine, haloperidol, loxapine, pyridazine, Malignant. Then newer antipsychotics like risperidone, olanzapine can also cause, antiemetics can cause, tetrabenazine, reserpine can cause, valproic acid, be careful, it can cause through mitochondrial receptor chain dysfunction. Lithium, which is a very unusual presentation, I'll show you certain videos, can cause. Flunarizine is an anti-migraine drug, can cause. Cinerizine, anti-vertiginous drug, can cause. Cardiac drugs, verapamil, known to produce Parkinsonism. This middle-aged person developed Parkinsonism. He was exposed to risperidone. This is a typical short shuffling gait with a diminished arm movements and slowness of walking with a lack of facial expression. So detailed history will reveal the diagnosis. This is an unusual case of a case of manic depressive psychosis. He is on a dual agent, lithium and sodium valproate. and he has developed Parkinsonism. He came to us with this kind of signs and symptoms, and his lithium level was very high. He's got features of Parkinsonism like slowness of walking, diminished arm movements, and also mild coastal instability. This interesting case, this girl had some emotional issues, started on escitalopram, there is by a general practitioner, and she came to me with this kind of movement. I could not believe, after taking history, I found she was taking Nexito, that is escitalopram, a typical Parkinson's disease. After stopping the drug and starting a dopamine drug, she got better. So sometimes escitalopram can cause surprise reaction in the form of Parkinsonism. I thought initially it's a juvenile Parkinson's disease, but to my surprise, I found escitalopram. Eventually, she got better after stopping the drug. She had a 2-3 follow-up with us, and she's doing well. This is a respiradone-induced unusual movement. It's called camptocormia. Along with Parkinsonism, they do have increased forward flexion of the trunk. It's called camptocormia. This boy came to me with signs and symptoms of Parkinsonism. Taking history, was taking aripiprazole, the newer antipsychotics. He has got typical Parkinson's signs of diminished arm movement, slowness with rigidity. So be aware of it. Newer antipsychotics like aripiprazole can also cause Parkinsonism. Another case of juvenile Parkinsonism. I want to share you this unusual case of every day, especially rum, and suddenly withdrawn due to some reasons. He has developed withdrawal Parkinsonism in the form of slowness of walking, mild resting tremors. Coming to the neuroleptic malignant syndrome, NMS is an idiosyncratic reaction. It's a hyperkinetic movement disorder. It is characterized by hyperthermia. The temperature should be more than above 100 Fahrenheit, associated with autonomic disturbances in the form of tachycardia, diaphoresis, labile blood pressure. They do have extraabdominal signs in the form of rigidity, dystonia, tremors, and then with elevation of muscles enzymes, CPK, and leukocytosis. They do have alteration of mental status like agitation, inattention, and confusion. Presence of fever and confusion makes you confused with the viral encephalitis. You should be careful. That's why detailed history is very important. According to DSM-4 criteria, one should have rigidity and a high temperature, plus two of the following signs like diaphoresis, dysphagia, altered mental status, tachycardia, dysregulation of blood pressure, leukocytosis, and elevated CPK. The incidence is around 0.5 to 2.4%. It can carry mortality rate up to 20%. That's why early diagnosis and intervention is always important in NMS. We should be careful. The pathophysiology being it's due to blockage of dopamine receptors along the pathway connecting the basal ganglia and the hypothalamus. Both older and newer antipsychotics can cause NMS. Now, they identified certain gene polymorphism, like D2 receptors of gene polymorphism. Such patients are prone to develop NMS. How do you manage? The best way to manage is, of course, you should stop the offending drug. In the abroad, they do have IV dantrolene. IV dantrolene is a drug of choice for the management of acute NMS. In India, we don't have. Either you can start oral dantrolene, or you can also give trial of bromocriptine and levodopa. Nowadays, we use injection apomorphine. Apomorphine is a rescue therapy in Parkinson's disease, can also be used in NMS. Levodopa also be effective in the management of NMS. This is the pathway is involved, which is connecting the hypothalamus and the basal ganglia. I'll show you a few videos. This guy came to us with a history of high degree temperature, along with rise CPK, leukocytosis, rigidity, and mild tremors. So we made a diagnosis of NMS. He was admitted in the ICU. After stopping the drug and starting on oral dantrolene and levodopa, he slowly got better. This is how this NMS features present with the rigidity, with this rise temperature, leukocytosis, rise CPK, and labile blood pressure. This to demonstrate presence of rigidity. So you can make out there's a resistance while flexing and extending the upper limb. This is a classically seen with patients with NMS, with the tremors and rigidity. Coming to Tardive syndrome, it's the most commonest movement disorders encountered in clinical practice. There is international criteria to make a diagnosis of Tardive syndrome. One is there should be a presence of abnormal involuntary movements, and there should be strong history of exposure to. It could be 3 months, 6 months, up to 1 year. According to revised criteria, in the elderly person above 60 years, even 1 month is sufficient to cause Tardive syndrome. And this disorder, that is, the signs and symptoms should persist up to 1 month after stopping. Chetan, am I audible?
Sir. Sir, the screen, it has stopped, sir. Yeah, it has started sharing, sir. Yes, sir. You go to the slide, sir, where you ended.
Yeah.
Yes.
So,
sir, you can maximize it, sir. Other fourth, sir. Fourth icon. Yeah, right, sir.
Yeah, no?
Yes, sir. Yes,
yeah. So, Tardive syndrome is a general term. Under this, you got 8 subtypes. You should be aware of it, all the psychiatrists. It could be Tardive Dystonia, it could be Tardive Dyskinesia, Tardive Parkinsonism, Tardive pain. Tardive pain is a recent terminology used. Then Tardive Tremor, Tardive myoclonus, Tardive Tourette, nothing but Tardive TICS. Then Tardive Akathisia and Tardive stereotypy. So 8 subtypes of Tardive syndrome have been identified in the clinical practice. I'll touch upon one by one. Coming to the Tardive Dyskinesia. Tardive Dyskinesia is a hyperkinetic movement disorder characterized by chorea. What is chorea? Chorea is nothing but involuntary, rapid, small amplitude, non-repetitive movements. It could be symmetrical or asymmetrical. See, when you notice a Tardive Dyskinesia, you want to just go through all this graphic diagrammatic representation. You start looking at the tongue and the mouth, perioral region. This is the earliest sign of Tardive Dyskinesia. In the OPD practice, if you don't have time, I just observe the tongue and the mouth, perioral region. You can make out any abnormal movements. It is the earliest sign of Tardive Dyskinesia. We can subsequently patient develop hands and legs. Of course, after the perioral region, they develop the face, upper part of the face as well. Eyes, they can have eye blinking, increased eye blinking or blepharospasm. Then respiratory muscles are involved. Laryngeal muscles are can also be involved. So this is the typical Tardive Dyskinesia with the various graphic presentation of how they move, how they show involuntary movements right from the tongue, perioral region. Again, here they do have grimacing of the face, lip smacking, tongue protrusion, puckering of the lips, and if it extend beyond the face, they can involve the leg, upper limb, etc., and the whole body. So earliest way look at it is the perioral region, especially the tongue and the perioral muscles. Coming to the epidemiology, 20 to 50% of all neuroleptic patients can develop Tardive syndrome. They have studied on the large scale, and they found 20 to 50% of patients who are on neuroleptics can develop Tardive syndrome at one point of time or other. It increases with aging. 72% is commonly involves the orobuccal lingual dyskinesias. 30% can have tremors. 22% can have akathisia. 16% can have dystonia. 4 and 1% patients can have tardive tics and myoclonus. And one interesting aspect is 35% of the patient can have more than one movement disorder, which I showed you earlier a few videos. The term Tardive Dyskinesia was first coined by Schoenecker way back in 1957, exactly 5 years after the invention of the discovery of chlorpromazine. Initially, it is called dystonia tarda. Subsequently, it was replaced by Tardive dyskinesias. What is the prevalence rate? It's around 25.3%. With the older antipsychotics, it still is higher, 30%, and with newer antipsychotics, that is second generation antipsychotics, around 20.7%. The commonest, both older and newer antipsychotics can cause, the commonest theory put forward is the blockage of dopamine receptors. Following a blockage of D2 receptors, there will have supersensitivity reaction in the postsynaptically, because the dopamine receptors become more sensitive postsynaptically and causing this kind of movements. So we should look at both older neuroleptics as well as non-neuroleptic drugs. Then genetic factors, which I highlighted previously, D2, D3 receptors, gene polymorphism have been identified in certain group of patients whom we see come across very early onset of Tardive dyskinesias. These are the older and newer antipsychotics. People are aware of it. Older antipsychotics, elaperidol, fluvenizine, trifluvenizine, perfenizine. This is a very interesting graphic representation of the evolution of Tardive syndromes. We should every psychiatrist should remember this one. Within 3 to 4 hours, one can see acute dystonia, sometimes acute akathisia. Within 3 hours after exposure drug. Between 3 hours to 3 weeks, you can develop Parkinsonism. From 3 weeks to 3 months, you can have Tardive Akathisia. From 3 months to 3 years, you can have other Tardive syndromes like dyskinesias, dystonia, etc. Tardive dyskinesia is the most disabling disorder compared to other Tardive syndrome because they can be devastating in certain group of patients. That's why early diagnosis and early intervention is always better in Tardive dyskinesia. It can block in several ways. Commonest is an nigrostriatal. It can block the mesolimbic system, tuberoinflammatory system. How to make early diagnosis? I want to stress here, all the psychiatrists should have their so-called AIM scale in their OPD. It's called Abnormal Involuntary Movement Scale. It's very easy to apply, hardly take 5 to 10 minutes. It's a 12-item scale, scoring scale, which can easily apply and easily identify the early onset of Tardive dyskinesias. I'm going to highlight here. It has got 12 questionnaire right from analyzing the face of facial expression, muscles of facial expression, the lips and perioral region, jaw muscles, tongue muscles, then extremities, both upper and lower limb, then truncal movements, then global judgment and dental status. These are the very important items to be looked into it in a busy OPD. You apply just for 10 minutes, you can make early diagnosis. The reason why diagnosis, I'll show you certain videos where we identified very early. Unfortunately, some patients comes to us very late stage. When you how to examine with the AIM scale is, you should ask the patient to relax on a chair without arm. There's an armless chair because hand should be free enough to make to identify any movements in the hands along with the face and the tongue. So patient should relax and remove any socks or shoes should be removed to look for the toes and ankle movements. And patient should ask to stand up and walk in the OPD itself and to make any to look for the truncal movements. What are the risk factors of developing Tardive dyskinesias? As I told earlier, age is very important. Advanced age, elderly person, be careful while starting neuroleptics. Always starts with a small dose. The other risk factors being pre-existing disorders like substance abuse, mental retardation, head injury, dementia, schizoaffective disorder, alcoholism, diabetes, HIV positive. These are the people who are prone to develop early tardive dyskinesias. Coming to the remission rate, see, I broadly classify into 30% group. 30% tardive dyskinesia do well. Another 30% they can have mild tardive dyskinesia without much disability. In another 30% they can have devastating illness. That's how I classify into 30% group. There's a various studies done showed the remission rate from 1% to 30%, 62%, 47%. What are the differential diagnoses? When you're in doubt, you should always revise your diagnosis. Whether I'm missing Huntington's disease, because Huntington's disease can be mistaken for tardive dyskinesia. How to differentiate? In Huntington's disease, upper part of the face is very early involvement, like involving the eyelids, then procerus muscles. This is the earliest sign in Huntington's disease. Whereas in tardive dyskinesia, it's the lower part of the face, that is the tongue and the mouth, perioral region. That's how we differentiate between Huntington's disease and tardive dyskinesias. Of course, family history, genetic history will be there. Wilson's disease, which is commonly mistaken for tardive dyskinesias, because they do manifest with a perioral dyskinesia sometimes and dystonia as well. Neuroleptic is another neurological condition. They can present with psychiatric manifestation in the form of psychosis, behavioral changes, dementia. They do have dyskinetic movements around the perioral region. Prion disease, then iron metabolic disorder, it's called MBAE, Sydenham's chorea, antiphospholipid syndrome, autoimmune encephalitis, which is now very common in day-to-day clinical practice. They do develop tardive dyskinesia leg picture. When you are in doubt, always subject the patient to neuroimaging that includes even the SPECT scan, genetic testing, and metabolic and autoimmune profile. Minimum 3 months required, but in elderly person, only 1 month is sufficient to cause tardive dyskinesias. Both older and newer antipsychotics can cause. These are the drugs which are known to produce tardive dyskinesias. Older antipsychotics and the newer antipsychotics. In between, we have antiemetic drugs like metoclopramide, antipsychotics, antiemetic, antidepressant. SSRI can cause tardive dyskinesias. Anticonvulsants, phenytoin can cause, pharmazepine can cause, then antihistaminic sometimes can cause. What are the subtypes of tardive dyskinesias? In clinical practice, commonly you see orobuccolingual dyskinesias. Very uncommonly, you can have respiratory muscle dyskinesias, laryngeal muscle dyskinesias, and generalized dyskinesias. I'll show you certain videos. Constant lingual movements can give rise to hypertrophy of the tongue. It's called macroglosia. This is an elderly lady exposed to acetalopram. She developed typical tardive dyskinesias. It's nothing but you can just make out puckering of the lips, lip smacking, repeated tongue protrusion as well. This guy is developed exposed to risperidone and respiratory dyskinesias. You can make out he's having breathing difficulty. It's a very uncommon manifestation of tardive dyskinesia. He's having breathing difficulty as well. This guy exposed to haloperidol, more than one movement disorder. He's got a dyskinesia, bruxism, and then some kind of stereotypic movements of the hands and legs. These are the stereotypic movements. So more than one movement disorders can be seen in a given patient. This elderly lady exposed to levosulfide. Levosulfide is a gastrointestinal drug. It's again abused by this gastroenterologist. She came to me with perioral dyskinetic movements. Detailed history with levosulfide she was taking along with these are older antipsychotics, haloperidol, dyskinesias. want to highlight here, recently we found two patients, very early stage, Tardive Dyskinesia. So I'll show you this. This came to me with very minute movements in the perioral region. And she was taking risperidone. After stopping the drug, and she eventually got better. That's why early diagnosis is very important in Tardive Dyskinesia. The earliest stage is you always observe the perioral region and the tongue. Similar case, this guy also developed able to pick up at very early stage of Tardive Dyskinesia involving the perioral region. Both are doing very well. This elderly man he developed more than one movement disorder. Already Tardive Dyskinesia developed Parkinsonism as well. This is a respiratory dyskinesia. This is an unusual manifestation of neuroleptics. She had breathing difficulty. And while on tetrabenazine, our symptoms almost disappeared. Another video, laryngeal dyskinesia is caused by neuroleptics. You can make out a breathy voice. The only way to document is the laryngoscopic study. You are subject a patient to laryngoscopic study. There is a laryngoscopic study of showing abnormal vocal cord movements. They do better with a local botulinum toxin injection. This very interesting lady came to us with this kind of movement. It's a case of manic depressive psychosis. She was taking lithium. So lithium unusually can cause dyskinesia. It's a case of a generalized dyskinesia actually. Our lithium level was more than 3.2. Stopping the lithium and starting anti-dyskinic drug, she got better. So lithium can surprise with Parkinsonism, which I showed you earlier, as well as dyskinesias. Pathophysiology, I already told you, it's mainly a dopamine receptor blockage. How do you prevent tardive dyskinesias? It's a very interesting area to touch upon. These antipsychotics are abused both by general practitioners and general medicine people, as well as neuropsychiatric group of people, I'm telling you. Because for small reasons, they start with antipsychotics. That's why we should be wise enough to start with the patients who really required antipsychotics. Most of the time, we can just manage with a simple lorazepam or Ativan, so-called Ativan, rather than using straight away with antipsychotics. So wisely use this selectively to those who really required. Then in advanced age group of people should be very careful. Always start with a small dose. Use preferably second generation rather than first generation. Of course, second generation, we are more wiser, can cause tardive dyskinesias. You escalate the dose very slowly. Don't escalate very fast. Okay, try to use one antipsychotics rather than dual antipsychotics. You should always inform the caregivers as well as patient while you put on neuroleptics because of the possible side effects. Then always apply AIM scale, which I highlighted you earlier. AIM scale is the only way to make early diagnosis. Even though you are busy in the OPD, carry always AIM scale and apply in your day-to-day practice. How do you manage? One is you reduce the dosage depending upon the severity of tardive dyskinesia. So you reduce the dosage of pre-existing antipsychotics and see whether is there any making any difference. If you still the patient continues to have stop the drug, then give a trial of dopamine depleters, so-called tetrabenazine. Start with a small dose, increase up to 100 milligram. In US, they have got two different drugs. Unfortunately, we don't have in India. It's called a newer variant of tetrabenazine. It's called valbenazine and tetrabenazine. This both group of drug approved by US FDA in 2017. This has got major advantages over the tetrabenazine. Tetrabenazine can cause Parkinsonism, can cause depression, can cause akathisia. Whereas valbenazine and tetrabenazine, they got lesser side effects when compared to tetrabenazine. And what the authors in the recent studies claim is that with the valbenazine and tetrabenazine, we can still continue the pre-existing antipsychotics. We will not change. That's the advantages of using valbenazine and tetrabenazine. I hope some of the pharmaceutical companies like Sanofi can bring out this valbenazine and tetrabenazine to India, because it's very found to be very useful for the management of tardive dyskinesias. There is the picture showing the various characters of and side effects profile of these three types of drugs, so-called tetrabenazine, deutetrabenazine, valbenazine. Deutetrabenazine and valbenazine has got lesser side effects as compared to tetrabenazine. The dosage for recommended dosage for deutetrabenazine start with a small dose 6 milligram, slowly increase up to 48 milligram. Whereas valbenazine start with a 20 to 40 milligram, gradually increase up to 8 milligram. And usually cardiac side effect profile are less, depression is less, and hepatic impairment is better than tetrabenazine. Coming to the tardive dystonia, the drugs which are known to produce tardive dyskinesia can also cause tardive dystonia. Dystonia, as I told earlier, is nothing but excessive involuntary muscle contraction resulting in abnormal posture or repetitive and twisting movements. It could be intermittent or sustained. It could be focal, segmental, hemi-generalized or generalized. The prevalence rate is around 1.5 to 2%. Minimum 3 months required. In elderly person, 1 month is sufficient. What are the various subtypes of tardive dystonias? We have cervical dystonia, oromandibular dystonia, blepharospasm, lingual dystonia, as well as generalized dystonia. Most characteristic feature of tardive dystonia, please remember, it's a torticollis, retrocollis, characterized by backward posture of the neck with a truncal arching backward and internal rotation of the arm and extension of the elbow joint and flexion of the wrist joint. This is the most common presentation of tardive dystonia. See, in dystonia, we've got varieties of type. The most common is in drug-induced is retrocollis. Whenever you see this kind of patients, 90% of the cases it's drug-induced. You'll be 90% of the cases you'll be right to make a diagnosis of drug-induced tardive dystonia, and remaining 10-15% we find other causes. I'll show you certain videos. This patient on chloroform and he has developed a mild cervical dystonia with Parkinsonism as well. This young guy exposed to risperidone and he has developed a lingual dystonia. You can make out the hypertrophy of the lingual muscles. He had difficulty in speaking and swallowing as well. After stopping the drug and starting on anti-dystonic medication, he slowly got better. So risperidone can also can cause a focal lingual dystonia. Be aware of it. This is a young girl who was put on newer antipsychotics called lorolazidone, and she came to me with cervical torticollis in the form of retrocollis. You can make out the backward she was taking, I think, 20 to 40 milligram of lorozolidone. This again another case of risperidone-induced cervical dystonia with mild Parkinsonism as well. This girl exposed to ziprasidone is another newer antipsychotics. She came to me with severe painful spasm in the form of retropolis. She was almost crying in the OPD. It was very painful spasm. After stopping the ziprasidone and then we started an anti-dystonic drug, she got better slowly. This respiratory-induced lingual dystonia. There's another case of causing cervical dystonia. Risperidone-induced oculobaric crisis. Upward and lateral elevation of the eyeball. Risperidone can cause truncal dystonia. This is levosulfide-induced lingual dystonia. So levosulfide can cause tardive dyskinesia as well as tardive dystonia. I'll show the classical tardive dystonia. The sulfide-induced tardive dystonia. We make out severe retropolis with internal rotation of the arm, extension of the elbow, and mild flexion of the wrist joint. Whenever you see this kind of patients, always think of Tardive syndrome. Another interesting case is called rabbit tremor syndrome. Again, induced. We can make out the rhythmic tremor of the jaw muscles, nothing but rhythmic contraction of jaw muscle. It is mimicking a chewing habit of a rabbit. That's why it's called rabbit tremor syndrome. Again, induced by neuroleptics. This elderly man was exposed to arpitrazole. He developed so-called Pizza syndrome. Pizza syndrome is nothing but increased curvature of the spine. It's almost bending to one side. This is called Pizza syndrome, induced by the arpitrazole. He also has got camptopormia, forward flexion of the neck and the trunk. We stopped actually episode and put him on clozapine, but he didn't do. Unfortunately, we had to remove even clozapine also. After stopping all the antipsychotics is better, but there's a chance of relapse of psychosis. That's a problem with this kind of patients. Another case of rabbit tremor syndrome induced by neuroleptics. I'll show you an interesting case of tardive blepharospasm. It could be intermittent or sustained. Again induced by neuroleptics. You can make the spasm of the both eyelids simultaneously. It's called tardive blepharospasm. How do you manage? Of course, you depend upon the severity. You have to start reducing the pre-existing antipsychotics, that is the offending drug. Give a trial of various. We can start with a small dose of triaxiphenil, gradually build up. You can give a trial of baclofen, clonazepam, of course, tetrabenazine. Then, if it is a focal dystonia, we can use botulinum toxin. What will do in the medically refractory case of tardive dystonia? We have to discuss with the patient as well as caregivers. We can subject the patient to lesionectomy called palliatomy or even the DBS GPI. They do well actually. Coming to Tardive stereotypies. These are the newer terminology used in the Tardive syndrome. Tardive stereotypy is nothing but involuntary pattern, repetitive, continuous, coordinated, purposeless and ritualistic movement. This is a monotonous movement. And it could be simple as exemplified by the body rocking movements. It could be complex as exemplified by crossing and uncrossing of legs, marching in place or pacing. I show you one or two videos. This is a neuroleptic induced tardive stereotypy. There is a monotonous movement, just repetitive clapping of the hands. Another case of tardive stereotypy involving the face. She keep marching. That's a monotonous movement. Same movement repeatedly doing. Coming to Tardive Akathisia. The clinical phenomenology is similar to Acute Akathisia. I already showed you in the previously. The only difference is that the duration of exposure of neuroleptics, minimum 3 months. They do have focal pain and moaning sensation. These two features differentiate from Acute Akathisia. Majority are caused by neuroleptics blocking the dopamine receptors. I'll show you one or two videos. This elderly lady in a chronic Tardive Akathisia, you can make out she's very restless, moving, keep moving, and with stereotypic hand movements. Treatment, of course, you should stop the offending drug, and you can give a trial of propranolol, clonidine, clonazepam. Coming to drug-induced tremors called tardive tremors. Tremors is nothing but rhythmic, involuntary, oscillatory movement occurring across a particular joint. It could be a resting tremor or action tremor or postural tremor. Majority of the cases is exaggerated physiological tremor. I'll show you certain videos which may be mistaken for Parkinson's disease unless until you have a proper drug history. So it's a typical pill-loading tremor of Parkinson's disease. It could be unilateral. This lady had got bilateral symmetrical tremors. This guy was admitted in the ICU, a case of dementia, was put on dual antipsychotics by outside practitioners. He was taking olanzapine as well as pimozide, and he done jaw tremors. He developed jaw tremors. He can make out rhythmic movements of the jaw. This elderly lady taking valproate epilepsy, and she developed a tremors, peripheral hand tremors. Interesting case of drug-induced, neuroleptic-induced Parkinsonism along with the resting tongue tremors. Tremors only involving the tongue. These are the drugs which are known to produce Tardive Dystonia, both the older and newer antipsychotics, antiemetics. How to manage tardive tremors is you should reduce or stop the offending drug. We can give a trial of clonazepam, propranolol, and primidone. Coming to drug-induced myoclonus, is an uncommon manifestation of Tardive syndrome. Less than 1% in clinical practice you see Tardive myoclonus. There are two types of myoclonus. One is positive, other is negative. Positive is nothing but due to sudden brief muscle contraction, like sudden jerky movements. Negative means there is a pause in muscle contraction, what you call as acidaxis, flapping tremor in hepatic encephalopathy. It's due to mainly you can see increased level of GABA in those patients. The drugs which are known to produce tardive myoclonus are mepridine, hydromorphone, verapamil, tricyclic antidepressant, sometimes SSRI, monoamine oxide inhibitors, lithium can cause, levodopa can cause in excess dose. I'll show you certain videos. This elderly man was admitted in ICU and they noticed to have myoclonus, jaw myoclonus. Fluoxetine can cause myoclonus. This is a case report. Fluoxetine was used for his behavioral problem in so-called frontotemporal dementia. You can look at sudden jerky movements of the shoulder muscles. This is called tardive myoclonus. Tardive myoclonus can also be seen in neuroleptic. Sudden jerky movements involving the neck, shoulder muscles. Coming to Tardive TICS, it's called Tardive Syndrome. It's again uncommon. Around 4% percentage of group of patients with Tardive syndrome can have TICS. It's a hyperkinetic movement disorder characterized by repetitive stereotypic movements. It could be simple or complex. It could be involving motor component as well as a vocal component, a combination of both. Usually they have got these following features: an urge to perform the movement, relief after performing the movement. They get a mental relief after performing the movements, and it can be temporarily suppressed with a change of attention. Usually it involves the craniofacial muscles. It is due to enhanced dopamine levels. Many drugs can cause methylphenidate, which is commonly used in ADHD patients, can cause tics. Lamotrigine can cause, antidepressant like sertraline can cause, humulin can cause, dextroamphetamine, cocaine can cause. And even antipsychotics. Recently, I read arpiprazole can cause tics. Be aware of it. Arpiprazole. Now, this lamotrigine, which is both used by both neurologists and psychiatrists, can cause tics. Here, in this case, the patient has developed facial tics. We observe closely some repetitive movements involving the face. Sertraline can cause tics. This on sertraline for depression. a neuroleptic. This is neuroleptic induced tics. You can make out is just observe eyes, repetitive monotonous movements. After stopping the drug, the eye movements they got better actually. Another case of tardive tics involving the neck and the shoulder muscles. They got subtle jerky, circle, monotonous stereotypic movements. Coming to tardive pain syndrome, which is recently described. Some of the patients who are having tardive dyskinesia, akathisia, and dystonia, they do notice chronic and discomfort pain involving the perioral region as well as genital area. It can be sometimes very disturbing to them. That's why you should ask detailed history of any, apart from this dyskinesia, akathisia, dystonia, any other signs and symptoms. They do better with the drugs used for akathisia and dystonia and dyskinesias. Conclusion: the drug-induced movement disorders quite common in our clinical practice, both inpatient as well as outpatient. One should have a thorough history, medical history, especially drug history. Any recent adding of new drugs or change of dosage of the drugs or frequency of change in frequency of the drugs. Apply always. Early identification plays an important role for the better management and better outcome in especially in tardive dyskinesias, because tardive dyskinesia is the most disabling tardive syndrome compared to other tardive disorders. Regularly apply the AIM scale in your OPD. You will hardly take 5 to 10 minutes. Then the best therapy depends upon the way you practice. You did not start always tetrabenazine or other drugs straight away. First, you start reducing and see whether we can make any difference. But you should closely follow up. You should not allow it to grow for a longer period of time. If still continuing, then you stop the offending drug and change over to another drug. If still continuing, then you can start dopamine depleters like tetrabenazine. But with the presence of tetrabenazine or valbenazine, actually it can make a difference to the patient, because what the authors claim, you can still continue the previous antipsychotics what you are taking within the when you put on patient with the tetrabenazine or valbenazine. I hope one of our pharmaceutical companies will bring that drug to India. This is a flow chart to show of management of tardive, especially tardive dyskinesias. Previously, we used to use a lot of this benzodiazepine, paracetamol, vitamin K, ginkgo biloba, which are of no use now. The most effective treatment still could be tetrabenazine in India, but in abroad they're using valbenazine or tetrabenazine. If you find adequate response after adding this drug, fine. If you find inadequate response, you can switch over to clozapine. If still finding problem, if you find focal dystonia, dyskinesia, you can use a trial of botulinum tox injection or ultimately surgery like DBS. Thank you.
Thank you, Doctor. I now welcome all the attendees for the Q&A session. I'll be taking a few of the attendees also as a panelist, so that you can directly ask any doubts if you have. You can directly ask the doctor.
think they learned something. I hope.
Dr. Sunil sir, Pratik sir. Any particular questions to be posted, you can directly ask, sir. Now you are visible on the screen too. This they may be a bit hesitant to ask. So yeah, doctors. Other thing is like since you all have the contact numbers of my colleagues, yeah. From Dr. Nivia Jacobson, we have got a message saying that it was a very informative session, and thanking you, Karke. So, sir, if you have any doubts, doctors, not only now but over a period of time also, Dr. Sanjeev sir will be very much reachable. And since you all have my colleague's number, you can directly call up Sanjeev sir. If not through my colleague, you can reach Sanjeev sir at any given point of time and get your doubts clarified. Sir will be will be loving to address all the doubts of yours at any given point of time. Even Shashi sir has messaged us saying that it was a very informative session, and thanking you, Dr. Sanjeev CC sir. So probably because of the time constraint and other things. So that is all. Doctor, I take this opportunity to thank especially Dr. Sanjeev CC sir to have taken us through a marathon session of briefing us each and everything related to